I think one of the big misconceptions is that this is just a quick shot. When I spoke about the needle length reaching the muscle, we talked about not administering in the intended space. And this is a patient's treatment regimen. So it is not just a quick shot. It is treatment, and we need to get it where it is supposed to go so that the patient's cancer treatment is not impacted.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Caroline Clark, Director of Evidence-Based Practice and Inquiry here at ONS, about the oncology nurse's role in administering intramuscular injections in cancer care. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks for joining us today, Caroline.
Thank you. So happy to be here.
So let's start with some background on intramuscular or IM injections in oncology. What drugs or solutions are commonly administered as IM injections?
Sure. First, to start broadly, we administer a lot of vaccines in the oncology setting. These are largely given intramuscularly, and most commonly, the vaccines are administered in the deltoid of the arm. And then there's very few cytotoxic agents that might be administered intramuscularly for cancer treatment. An example of one is IM methotrexate in some treatment regimens for gestational trophoblastic disease. But more frequently, oncology nurses are using intramuscular injection techniques when giving certain hormonal therapies for cancer treatment and for cancer symptom management. Some examples of those are fulvestrant for treatment of hormone receptor positive HER2 negative breast cancer, leuprolide as androgen deprivation therapy in prostate cancer. This is also used off-label for breast cancer management. It's used for premenopausal ovarian suppression and also in non-cancerous conditions like endometriosis and uterine fibroids. Oncology nurses might also be administering depot injections of somatostatin analogs. So one example is octreotide for diarrhea and flushing related to metastatic carcinoid tumors. And these intramuscular administered therapies are used alone, or they're used in combination with other agents and treatment modalities that oncology nurses will see in practice.
We know that site selection is an important consideration for IM injections. What should nurses consider when they're choosing an injection site? What are the areas that are the most optimal, and maybe what areas should nurses avoid?
Site selection, I think first just starting with visualizing the skin, general considerations, avoid sites with erythema, rash. If you see scarring, you want to avoid those particular sites. And then nurses should consider the volume of the injection that they're administering and choose a muscle that's large enough that's going to accommodate that volume. There also may be some manufacturer guidance on site selection or what sites to avoid. So one example of that is prescribing information for Sandostatin LAR cautions against use of the deltoid due to discomfort it can cause at the injection site. So you want to check your manufacturer recommendations. If we're talking about vaccines, most optimal sites for IM vaccine administration is the deltoid for adults. For children and adolescents, the deltoid or the vastus lateralis, that muscle running down the anterolateral thigh, can be used. And I'd really recommend that if you're in a clinic that delivers a lot of vaccines, that you check out the CDC site on administration. It goes over needle length, giving multiple vaccines in a day, co-administration considerations for giving those most painful vaccines last and in separate arms. And we can share links to helpful websites in the podcast resources. So I want to go back to the endocrine treatments that we discussed. There's octreotide depot and fulvestrant. They're most often given in oncology settings, administered in the gluteal area. And this includes two potential sites of administration, the dorsogluteal and the ventrogluteal areas. Leuprolide is also given in the gluteal area. It does have manufacturer recommendations that allow for administration in the deltoid or in that vastus lateralis. For vastus lateralis, that large muscle in the thigh, is less commonly used for some of these agents because of those manufacturer recommendations for administration in the gluteal area. which is what we're going to focus on a lot more today. But the vastus lateralis might be a reasonable alternative when gluteal administration is not possible. The gluteal region includes three major muscles, the gluteus maximus, medius, and minimus. So the dorsogluteal injection is into the gluteus maximus, or that upper outer quadrant of the buttock, and the ventral gluteal injection is lateral just under your iliac crest, with injection given into the gluteus medius. And then that last muscle, the gluteus minimus, is partially underneath that muscle. So you may see package inserts, and you definitely will see package inserts that indicate gluteal area for administration. Both are considered a gluteal area. The ventral gluteal area has some clear benefits over the dorsogluteal area and is recommended as the safer of the two choices. Most importantly is just considering what's underlying that site, what neurovascular structures are underlying. So anatomically, the gluteus maximus at the dorsogluteal site, it lies over the very large sciatic nerve, and it's in proximity to the gluteal artery. So inadvertent injection into the sciatic nerve is one of the most common causes of sciatic injury. It has significant morbidity associated with it. And even for drugs like fulvestrant, the prescribing information notes reports of sciatica, neuropathic pain, neuralgia, peripheral neuropathy, all related to dorsogluteal injection.
Thank you so much for reviewing all of those anatomical sites, kind of taking me back to anatomy, but definitely helpful to review and to remember. So for those preferred muscle groups, what are the volumes of injection that are acceptable to be given?
The deltoid maximum is 2 mLs. And then for both gluteal sites, it ranges from 3 to 5 mLs.
Okay, that's good to review. In considering, there's several other factors that come into play for IM injections, such as needle length, muscle thickness, subcutaneous thickness. All of those things have to be part of that decision making. Can you give us an overview of how those factors affect administration of IM injections?
Sure. All those factors are really interrelated. The factors to consider are the subcutaneous adipose tissue that's over the muscle, so that skin to muscle measurement. And those measurements are done in a variety of ways in the literature. They're done through review of MRIs, ultrasound, and CT scans. Measurement data comparing both gluteal sites reveals that the dorsogluteal site has a larger subcutaneous layer, and the thickness is really variable. And then at the ventral gluteal site, there's less subcutaneous tissue to go through before hitting that target muscle. And that's a good thing. The risk with that thicker subcutaneous adipose is that you could inject into the subcutaneous space instead of the intramuscular space. And as you know, this is going to impact absorption of the drug, the intended effect. It can cause inflammation, infection, some other issues. Additionally, the muscle thickness at the ventral gluteal site, it's more consistent in measurement throughout. And that's helpful too, because you have that more consistent muscle thickness. So you're getting good absorption there. There was a meta-analysis recently that also found ventral gluteal injection resulted in less pain for the patient, less risk of bleeding and hematoma. And then for needle length, we'll talk a little bit more about this, but a 1 to 1.5 inch needle is standard for an IM injection, can definitely be influenced by body composition.
Well, speaking about body composition, we know that our patients can be various sizes and shapes. And so what do we need to know about IM injections for patients who are either morbidly obese or cachectic?
Obesity is certainly a concern in this country, and it's something that we should consider as we talk about the evidence. So the major concern with obesity is, will the needle reach the muscle as intended? And as I said, that ventral gluteal site has less of that subcutaneous adipose to get through compared to the dorsogluteal site. However, females, we know, have a greater thickness of subcutaneous adipose compared to males at that site. So a great question that's come up is if the BMI is going to influence that skin to muscle thickness, that adipose that we have to get through to get to the muscle. So I read one systematic review that found BMI did not affect that thickness at the site, but this had very few studies. Multiple others found that BMI did in fact influence the subcutaneous thickness, more of a concern in females. One was a retrospective review. There was 350 participants. It found that subcutaneous thickness at the ventral gluteal site was influenced when BMI was greater than 30 in females and greater than 35 in males, indicating obesity. And then another review of 119 adults found that the thickness at the ventral gluteal site and dorsogluteal site was influenced by BMI 25 or greater in females. And authors concluded that the risk there was that the standard 1.5-inch needle may not reach the muscle as intended at that BMI. Then for the dorsogluteal site, this was confirmed by another review using CT scans and ultrasound measurements. And in that study, 25 was the cut point for BMI in females and 35 for males, where a longer needle would be needed to reach the muscle. And so, what I gleaned from that literature in preparing for the podcast today was that BMI greater than 25 in females was where failure rate was higher, especially in the dorsogluteal site with a 1.5-inch needle. And then in the ventral gluteal site, BMI 25 to 30 in female was where there was also a higher risk. In males, 35 of the BMI was the kind of the cut point for the gluteal sites. It's a really critically important consideration for treatment because it can lead to treatment failure. Notably, some manufacturers do state that for patients with greater skin to muscle depth, a 2-inch needle may be used. If you're working at a site that administers in the gluteal region, you may want to evaluate needle length options based on the evidence. So going back to your question, conversely, what about cachexia? So for patients with muscle wasting, low muscle volume, for those that are significantly underweight, use clinical judgment on needle size. A 5/8-inch needle is appropriate, and dividing the volume over 2 injections may be needed. So as I said earlier, there's a maximum volume in the deltoid of 2 mLs, but that's not going to necessarily be appropriate in instances of cachexia. When administering an IM injection to someone who is cachectic, you don't want the subcutaneous tissue to bunch up. So you can kind of stretch this over with your non-dominant hand, as in the Z-track method, and then grasp the muscle between your thumb and index finger. And that's going to help you ensure that you're getting that muscular injection. With all IMs, you want to insert that IM needle quickly and at a 90-degree angle. I'm not going to talk too much about the deltoid, but as I said, a couple of sites have good information about deltoid administration for vaccines. So immunize.org has specifics for needle length based on weight and biological sex for administering in the deltoid, and we can make that available to your listeners.
So in general, what are some risks that nurses should consider when they're administering IM injections?
Well, as we talked about, the neurovascular injuries are possible complications. So monitor for immediate pain, neuropathic pain, numbness, tingling. Look out for bleeding or hematoma formation. So it may be wise to review platelets and the medication list ahead of time. Does the patient have thrombocytopenia? Is the patient on anticoagulation therapy where you need to caution them to monitor the site more closely? There is a risk for infection. You want to consider the underlying structures based on the muscle group you're choosing. So as we said, ventral gluteal area is safer of the 2 gluteal areas due to the distance from the nerves and the arteries. So the main branch of the gluteal nerve, which innervates that muscle, is very distant from the injection site. For the deltoid, the risk when hitting underlying structures can result in shoulder injury related to vaccine administration, commonly referred to as SERVA. This can lead to bursitis, ligament inflammation, and rotator cuff injury. Those are some things that you should consider when you're administering an IM injection as potential risks.
Thank you for that. I think that's a great summary of just some of the things really to keep in mind. And it really does just make you pause that an IM injection is not simple. It's not something that you just do and move on. And so I really appreciate you taking the time to kind of point out and highlight some of these things that really should be part of the decision-making before that injection is given.
Right. I think we should eliminate that it's just a shot from our vocabulary.
Previously, you just lightly mentioned the Z-track method. Can you describe that Z-track method a little bit more and why should it be used for IM injections?
Yes, I think also we're going back to nursing school in this, but it's just good for a refresher. We talked about the importance of injecting into the muscle, and Z-track is a way that you inject that there's no leakage back out into the subcutaneous space. So you're going to clean your area as usual. You displace the skin and the subcutaneous tissue that's over that muscle, and then you inject slowly into the muscle. Once you remove the needle, then you release that tissue, and it kind of seals it over and prevents that leakage back up into the subcutaneous space.
As you said, a good review. Some of us, it's been a while since nursing school, and so it doesn't ever hurt to just remember the basics. So thank you for reviewing that for us. So when a patient receives an IM injection or any injection, of course, they have the risk of experiencing an adverse reaction. How should nurses monitor patients after they give an IM injection?
First, if there's manufacturer guidance on observing the patient after that injection, you should stick to that guidance. So monitoring for hypersensitivity, allergic type response is appropriate. Monitoring for pain related to a nerve injury is something that would occur right away. Advise the patient to notify the team with persistent pain, paresthesias, motor loss, and look out for bleeding. I think it's important at return visits that if a patient is complaining about a site where an IM injection was given, take a look at it. Does it look like there is erythema, infection? Injection-related injuries are largely underreported. So documentation and follow-up for any adverse event is important. It's not only for internal monitoring, but also just to add to the body of evidence around safe injection practices, kind of why we're here today. Shoulder pain and decreased range of motion following a deltoid IM injection may be indicative of that serva or shoulder injury related to vaccine. And that presents about 48 hours after IM deltoid injection. That can result in pain, decreased range of motion, extended recovery, and additional interventions needed like physical therapy.
Well, we've talked a lot about the basics and special considerations for IM injection, which I think has been so helpful just to kind of level set, get us all back to the basics and the foundation of how we do this procedure. But now let's talk about putting the evidence into practice. For two commonly used areas, the ventrogluteal and the deltoid sites, how can nurses use landmarks to properly administer injections?
Sure, I'll start with the deltoid. We've all given a high volume of vaccinations, especially over the last few years, that we're probably pretty comfortable with the deltoid site. But as a refresher, landmarking here involves finding the bottom of the acromion process at the top of your arm and administering 2 to 3 finger breaths below that. So the deltoid is really just an upside down triangle. You're administering directly into the middle of it. I think ventrogluteal injection is less commonly done. And so there's documented issues with confidence in landmarking and giving into that site. So practice is necessary. A great way to identify the ventrogluteal site on yourself to start is to stand up and put your hand at your side. You feel for that top, like that iliac crest. Place your hand right below the iliac crest and then just start marching in place. You're going to feel that muscle contraction right away. This also works when you abduct your leg. Abducting your leg is helpful when a patient is in a sideline position to give a ventrogluteal injection. You feel that muscle contraction. When you're administering in the site, as I said, the patient can be laying down on their side or they can actually also be standing. I'm going to discuss the technique laying down, presuming that people are less comfortable with ventrogluteal injection. But I'm going to talk about the V method for administration. After you get more comfortable with administration, landmarking, that's when a patient can actually stand up to receive these injections. But I feel the best way to learn to landmark is in that sideline position. So if the patient is side-lying, you place the heel of your opposite hand over the greater trochanter or that knobby prominence at the top of the femur. And it's the opposite hand than the side that they're laying on. So if they are laying on their left side, you're going to use your right hand. You're going to put heel of your hand on the greater trochanter and your thumb is going to be facing the patient's groin. You spread your hand so your index finger faces towards the front of the patient and your middle finger is really reaching back. And this is making a V. And between the index finger and middle finger is where the injection site is.
It's hard to visualize, but I really appreciate you giving us all the appropriate landmarks and describing, how the patient is laying, how we as the administrators are facing the patient and kind of which hand we use. So that was really helpful. It really was. Thank you for going through that. So you have some firsthand experience in actually implementing a practice change related to IM injections at your previous workplace. What was the proposed change and what was your role in implementing that change?
The proposed change was moving from routine dorsogluteal injection to ventrogluteal injection. And I should mention why that decision was made. It was due in part to an overview of the current evidence and anecdotal reports of patient adverse events and pain with dorsogluteal injection. So at the time, I was a clinical nurse specialist and I was supporting outpatient oncology areas. And my responsibilities in this change included education on the change management, staff and patient consults, including hands-on assistance for landmarking, and observing those skills in practice and fielding questions from the nurses and the patients.
We know change can be hard, even if it's the right change. So what role did you see from early adopters and practice champions that they play in the process of making that practice change? And how did they get others kind of to come on board?
So I think when we talk about change and change management in practice, we need to think about the why behind the change. And that needs to be really evident to the people we are asking to make that change. It's important to establish practice champions, and it's important that they really understand the evidence, they can speak to it, and they could kind of mobilize their peers to take on the cause, I guess. So I can't be in all places at once as the clinical nurse specialist. So having those dedicated staff champions available in the spaces where these injections were most frequently given helped with consults. It helped with the nurse's confidence, that landmarking support, knowing you had another person to kind of go in and landmark with you the first time you were doing this, and consistent communication to the patient. I can't really stress that enough. Patients should hear the same thing from every nurse about why this practice change was done. Some of the other things to help people get on board, shared governance and unit communication ahead of time is essential for any practice change. Review of the schedule of IM injections ahead of time and kind of planning who's going to be on the unit, who's going to administer, and then encouraging, as I said, consistency in the description of the practice change, both to the nurses and to the patients, and really the rationale for why the change.
Those are all just really great points to consider, especially, if any of our listeners are hearing this episode, they're inspired, they want to start implementing new practice at their own sites based on some of this same evidence that you've shared today. These are some great sort of starting points and for things for them to consider. Even along those lines, even the best laid plans still encounter barriers, challenges. So can you talk briefly about what some of those barriers and facilitators that you faced in making the practice change?
Sure. And some of the barriers are that resistance to change that we spoke about, confidence in landmarking. So for some, like just doing this once or twice, it really didn't instill confidence. They had to kind of put themselves in the position of doing this repetitively on the IM schedule in the units that they were administering. Patient resistance to change as well. So you have patients long-term that we're receiving in the dorsal gluteal site. And then we say, okay, we are changing our practice. So that was definitely a barrier and needed to be really treated sensitively because patient preferences and values, as you know, is part of evidence-based practice. So when there was resistance to change, we needed to make it clear what the evidence was for the patient and then kind of document if they absolutely refused what the risk was in the dorsal gluteal space. So that was definitely a barrier and something to navigate sensitively. What helped, what facilitated the practice change was having clinical site leadership, including your practice champions. Observation, I have to say, patients were very, very kind when I would say, like, we are making this practice change. Is it okay if one or two nurses come in during your injection to observe? They were so lovely in helping nurses to feel more comfortable. So observing an injection, I am very much a hands-on and a visual learner. So having a video that was approved by our patient education committee was helpful as well, so that you could review the video, then have hands-on landmarking. We also had patient education talking points for the nursing staff. The nursing staff felt prepared to field the questions. And we had a change in patient education resources about IM injection. And then, with all change over time, people became more comfortable with it. I think another facilitator that is important to mention is your policy and procedure manual updates should be clear for the nurses. One thing that I felt was not exactly sufficient for landmarking was the particular mannequin that we used. And I know that there's just some models that may be better than others. If you have a sim lab where you can really see as well the underlying muscle, that might be helpful. And then after, some comfort, many nurses opted to have a patient stand up. And this might be a patient preference. It could be a nurse preference. It could be both. I just, be mindful of patients that are at risk for falls and have them have some things to steady themselves with.
I really appreciate the important focus that you provided on the patient in all of this, because it really was a a two-layer change, if you will, getting the nursing staff educated, prepared, comfortable, and on board with making this change, but then also communicating it and making that change for patients. And so I think you provided some great things to consider in terms of how do we address both groups. Instead of focusing just on one, how do we focus on both? And so I think you provided some great examples of how to make sure that that is part of that change management.
Right, for sure.
Well, Caroline, I know I learned a lot. And I just sat back and listened to you teach today. So thank you so much for bringing all of this great information and the evidence that supports it, which we will link in our episode notes for those that want to follow up on some of those studies and things that you referenced. Thank you so much for bringing this information. Again, back to basics a bit, but also something that, as you noted, it's something that we need to stay focused on because we don't want to become complacent and assume that we have those skills remain sharp year after year. So I really appreciate your time today. As we get to the end of our episode, I do like to always ask a few wrap-up questions to help summarize some of the things that we've talked about. So to start that off, what are some common misconceptions about administering IM injections?
I think one of the big misconceptions is that this is just a quick shot. When I spoke about the needle length reaching the muscle, we talked about not administering in the intended space. And this is a patient's treatment regimen. So it is not just a quick shot. It is treatment, and we need to get it where it is supposed to go so that the patient's cancer treatment is not impacted.
What's something about this topic that's not often discussed, but you wish people knew more about?
I wish, and this really relates to it, it's just a quick shot. I wish it would be front of mind to encourage adverse event reporting related to any injection you're giving. These type of reports, they drive improvement measures and monitoring. And then when things are underreported, it leaves us to anecdotal reports. So really, monitoring any or change, trying to get some baseline data on adverse events with injection is really important. And then when I was preparing for the podcast today, something that struck me when I was reading more about sciatic injury, an older small study case series of 5 patients with neuropathic pain after traumatic IM gluteal injection revealed that these symptoms, the mean duration was 8 months with pain scores of 9s and 10s on numeric rating scales and necessitating multiple therapies. So even if it's not something you observed in your own practice, sciatic injury can really affect a patient's quality of life, pain, and have very long-term implications. So, I think that's important to know.
Absolutely. I agree. What additional training or education do oncology nurses need to stay current on this topic?
I do think the use of visual aids, if a nurse isn't sure about their technique or how to landmark, encourage the visuals, the videos, any sim lab or observation when others are administering in the ventrogluteal space is really helpful.
And what are some additional resources for patients or maybe other providers on the healthcare team who want to know more?
As you said, we'll put some references in the podcast resources. The CDC and immunize.org has great references on the vaccine administration using your manufacturer guidelines. Some of the manufacturers have injection support and their own visuals and instructions for injection. So I think those are helpful as well.
Well, Caroline, thank you again. I learned so much, and I know our listeners will as well. Do you have any final comments to share with our listeners today?
Thank you so much. This is a great topic, and I feel like it is nice to just review something that we might take for granted that because we've done it over and over again. So, staying current on the evidence on IM injection and technique, I think is something that is really important. And I hope that the listeners can use the resources we provide to encourage perhaps change in their policies and procedures at their institutions.
Thank you so much, Caroline.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.